Hello, everyone. Welcome to this edition of Ask the Experts. We will have Liz McIngvale. She'll be here any moment. She messaged us that she was running a little bit behind. I'm just turning on Do Not Disturb so I don't get a bunch of calls. She is running a little bit behind, but I'm going to start us off. So, welcome. If you are new here, Ask the Experts is a great opportunity for you to find out the resources that the IOCDF has, what different informational and educational programs are out there. It's to ask about books or materials. You can ask your questions. We can give you resources. So if you're really struggling with OCD and related conditions and you have a question about OCD or any related disorder like BFRBs, body dysmorphic disorder or hoarding disorder, today is the day for you. So I know a lot of times we have a lot of different guests on here. We always appreciate them. And then the first Wednesday of the month, rather, we always have an Ask the Experts where we really just answer your questions. So I know a lot of you like that and will say, hey, when can we ask questions? So this is the stream for you. So before we jump into questions, go ahead and say hi. Let us know where you are joining from. So where are you located? Also, who are you here to support? Do you have OCD? Do you have a kid with OCD, a spouse? Are you in a relationship with somebody with OCD? Who are you here to support? It's always good to find out who our audience is. Also, letting us know where you are on your OCD journey, how you're doing today. And don't forget, this is your live stream. So we're streaming live rather on YouTube, on Facebook, on Twitch, on LinkedIn, on X, iocf.org/live. So you have a lot of different options where you're watching us. So make sure you just let us know if you have any questions or comments or updates. This is the live for you. We also have pre-submitted questions that I'll get to in a second, but I want to make sure that we prioritize any questions you have live. So make sure to ask those questions away. Just a couple little housekeeping stuff. So remember that we are only an educational platform to give you answers to your questions. We can't provide crisis intervention. So if you are really struggling, please dial 911 or 988. You can also go to 988lifeline.org, reach out to your psychiatrist or your clinician, go to your local emergency room. I always tell people if you're really, really struggling, go ahead and please reach out to services that can help you. Also, don't forget, you can find a clinician near you if you are struggling and don't have any help. The IOCDF's I consider the bread and butter. It's why I still do all the stuff I do for the IOCDF, because I was able to find them and find a therapist that turned my life around from this very same resource directory. So make sure you go to iocf.org/find-help to find a clinician near you. Lastly, we're streaming live on all these different platforms. So ask questions, be respectful, and we are excited to have you here. My name is Chris Trondsen. I'm on the board of directors. I'm also a licensed therapist here in Orange County, California, treating OCD and related disorders. And I have OCD, so I also advocate, as well as I was diagnosed with body dysmorphic disorder, major depressive disorder. So any questions y'all have, we would love to answer them. I see people are saying hi already. Hi to our good friend, Matt Bannister. Suprap, it's good to see you over there on YouTube. Gail, it's good to see you from Cape Town. It's always good to have our buddies from all over. We have India in the house. Welcome. Hi, Spence. We have Houston, Texas in the house. We have a couple questions that I'm going to jump to. So let's just jump right in. It's good to see everybody. So welcome. And like I said, Liz will be here shortly. I look a little sweaty because I was running. I was telling Rachel from the IOCDF, who is our amazing staff member behind the scenes right now, our office has that bathroom where it's like you have to go all the way down the hill and around and like have a key. So I apologize for that, but I get my steps in each day, which is beautiful. All right, we have a question from Kay from YouTube. They say, I have OCD, but are there any tips to enjoy travel? Can traveling have a positive effect on OCD? So this question, Kay, is after my own heart. I would say one of the most difficult things for me with OCD was travel. I'd be curious if there's any things you have to overcome, Kay, to travel. But for me, I know I had OCD with my health, so I was really anxious about going through like the metal detectors or the scanners. I thought it would give me radiation poisoning or cancer, so I was afraid of that. Contamination OCD, I didn't want to sit on public chairs, having other people touch my stuff, like my suitcases and not briefcase, my suitcases and carry on is the word I was looking for. I didn't like people touching that. I was really, really afraid that I'd lose my luggage and then I'd have to like buy stuff when I was there and not have the same stuff that was safe. And I'd health stuff around using the same products because I knew I wasn't going to get sick from it or have a reaction. So travel was really hard for me. But what I can tell you is that one of the difficult things about having OCD is how much it limits our life so much and how it prevents us from really thriving and taking advantage of all those amazing things that life has to offer. And I would say traveling is great. You get to see areas and meet cultures and meet people you've never met before. I speak some Spanish. I like hearing, people speak it other places and practice speaking the language if you know it. I like trying new foods from cultures, seeing their different like face, seeing their different, just the way that different communities and cultures and races and ethnicities and religions are. You read about them or you hear about them. So for me, travel is meeting people from all over and sharing information. I don't know. I went to Norway and Iceland last year and I absolutely loved it. So I think traveling is so great. It does have a positive effect. It's funny because a client of mine yesterday, we were talking about it. She wants to travel more because she says it brings such happiness. Remember, you need something to challenge the OCD, in the sense that if all you're doing all day is having OCD, I think of it as watching a TV show or a network and all they play is OCD all the time. So when you get back to work and you have friends and you travel and you date and you do all these hobbies, now OCD has to compete with all these different stimuli. So traveling can help. What I'd say for how to enjoy travel, always remember treatment can be done in small steps. It does not have to be done overnight. And I think with that, Kay, is what you can look at is when it comes to travel, just making sure that you figure out like what are going to be the challenges that will come up. And can I practice that in a non-stressful time? So what I mean by that is, most of us can't just keep traveling to short trips and then long trips and then longer trips because that's pretty challenging financially and time consuming, right? But let's say you want to travel overseas. Well, is there public places you could sit if you have contamination? What is the trigger? Can you practice that on a smaller scale and then move it up and move it up? So for me, what really helped is taking small, more local trips, getting really comfortable with staying in a hotel, going to places that had metal detectors, so I could practice that. I mean, just basically starting short. I think lastly, remember, OCD is going to come up with a laundry list of what can go wrong. It never tells you what can go right. So make sure that you're focusing on the enjoyment and the reason you're traveling in the first place. But if you're okay with it, I think I could give you a better answer if you tell me what is kind of bringing up angst for you with traveling. But I will say it definitely has a positive effect. Anything, being in nature, spending time with friends, anything that gives you happiness and challenges the OCD is going to definitely make you happier. I know for me, traveling is so nice. I'm always come back relaxed and just happy. So definitely. Kevin asks at 12:04 your time, Rachel. He says on YouTube, I'm here to ask questions for myself. I live in, I think it's Michigan, unless there's a Michigan and I've not heard of it, but I think you're saying Michigan. I have a question for Liz. Liz is not with us currently, but I will try to answer it and I will see. Let me see if she, she didn't text me yet. She'll be here soon. But we'll ask that question when she's here, but I'll try to answer it until she gets here. I heard she treats OCD using ERP, but she does it without a hierarchy. Any quick tips on how to do that? So when I was at the BTTI, this was many years ago, Alec Pollard was talking about this. What he said is that what they found with the addition of inhibitory learning. So there's kind of two principal ways that we believe that ERP works. The first is going to be habituation. So I want you to think like if you're getting into a pool and the pool is really cold, but you stay in it for a while, it kind of warms up. That's kind of like habituating to the temperature. Or if you see a little kid and they're really anxious to go down the slide at the park, and then they go down the slide and they seem a little bit hesitant, but they keep going, they get more comfortable. Over time, using time instead of a compulsion. With habituation, we notice we kind of get used to it. So the trigger that bothered us at one point doesn't seem to bother us the same. And that was really the point of a hierarchy, is we didn't want to throw people into their, if you use a 1 to 10 scale, we didn't want to throw people into their 9s and 10s out the gate, because they most likely would be too freaked out to come back to treatment. But also, like, the goal of treatment isn't to overwhelm or shock yourself into getting better. It's really to learn and to watch that habituation process to see that you're getting better, you're getting more accustomed to something, it's not as triggering. Now, what we realized in the last probably like 15 years, or maybe longer, but that's really when I became familiar with the term inhibitory learning. What we started to recognize is there might be a different or additional, depending on who you ask, way that ERP works, and that's called inhibitory learning. And the idea of inhibitory learning is, right now, there's a set of things that we all agree kind of scare us and are dangerous. So like swimming with sharks with no gear, running in the middle of a freeway, knives being thrown at you, right? Like, we would all kind of nod our heads that those are dangerous. But what you may recognize, Kevin, and probably what other people watching recognize, is that there are other things that make you anxious and afraid that nobody else in your family or your life seems to either be afraid of or afraid of at that same level. And so inhibitory learning is teaching yourself through learning that, hey, this isn't as dangerous as I thought. And right now I have sort of this negative association with this trigger. It could be your kids if there's harm thoughts around children. It could be the Bible if you have scrupulosity. And by doing ERP, we're actually teaching ourselves, and we're learning that this thing is no longer dangerous. We're kind of, like Alec Pollard said, we're moving that thing from the dangerous category into the safe category. And so what we found is that people don't need to habituate as quickly as we once thought. It's okay if you do an exposure and don't habituate right away, because you're learning. Your brain is taking that information and recognizing that trigger is actually safe, and it's okay to keep using it or reducing compulsions or whatever that may be. So what Liz talks about, going back to your original question, is the hierarchy might not be as important. You could kind of work on things that are more important to you. Hey, Liz, good. I was answering a question on your behalf. So
good. I trust you. You don't need me.
Well, I was about to finish it, so I'll let you finish it. So Kevin asked, I have a question for Liz. I heard that she treats OCD using ERP, but does it without a hierarchy. Any quick tips on how to do that?
Yes. So I don't know, Kevin, if you're a clinician or an individual, so I can kind of speak to both. But for me, I think what I focus the most on, let me back up. Sometimes I use a hierarchy. So I just want to say that, because sometimes, especially if a patient like is new to OCD and they really need to see on a hierarchy, they need to understand how stepwise ERP would look for them. In those cases, I absolutely am doing a hierarchy, and I think it's really useful. But the reason I don't use a hierarchy all the time is because at the end of the day, what I'm most focused on is, do patients understand the concept of ERP? So are we less focused on using a hierarchy to get check marks? Like, oh, I did that exposure, I get a check mark. I did that exposure with response prevention, I get a check mark. And much more about, do I understand ERP as a whole? Right. So when we're doing ERP, I should kind of have a pretty good idea of, like, here's lower level exposures, here's mid-level exposures, here's high level exposures. Which ones are you willing to do with full response prevention? And then we can slowly start doing them. The goal with ERP is that when we're doing the highest level exposures and we're doing them with full response prevention, we shouldn't have to go back and do all the little ones that were in between or along the way, because it should have this domino effect of those higher level ones kind of change our relationship with anxiety for the lower and mid-level ones as well, if that makes sense. So when I say no hierarchy, it doesn't mean we don't do stepwise exposures. It doesn't mean we're not, making sure that we're doing them with full response prevention and slowly working our way up to the higher level ones. But what I mean is that I don't like doing treatment in this rigid way, especially because I don't want individuals to think that their entire life they need to make a hierarchy and be doing things on their hierarchy. Right. The long-term goal is that when you're doing ERP effectively, you're going to have freedom. You're not going to have to keep doing a hierarchy. So again, I want you guys to think a lot more about, and y'all know, Chris knows I talk about this all the time, but like, is the goal of ERP for us to address specific symptoms or to change our entire relationship with anxiety and OCD? right? When Chris or myself are doing ERP with any patient in our office, of course, we're addressing specific symptoms along the way, but that isn't the goal. Because if that's the goal, it is going to be this game of whack-a-mole that people talk about, where it's always new symptoms and new triggers, and we're having to do ERP for this one, then for that one. It's, did we use ERP in a way that, yes, it did, of course, address our current symptoms, but it helped change our entire relationship with anxiety and OCD.
Well said. That's a beautiful background, by the way.
Thanks. I have a speech training to amazing high schoolers here in Houston, so I'm out of
Uh,
school.
Wait, is that a
So,
school?
yes, isn't it
Oh, girl,
amazing?
you need to come to Long Beach, California. We did not have schools like that. I keep telling because the advanced
I
forum
know.
meets
It's like,
guys, and I know the advanced forum is for clinicians in October is in Long Beach. So I'm so excited people can see my hood that I grew up in, but we will not be
yes,
seeing schools like that. Let me just tell you. But you know what? I
I
love it.
love it.
That's what I grew up in, but
Okay,
that's a beautiful school.
thank you. Agreed. Agreed. I agree. Okay, so let's hop to 1108 for my time from Luis. How do you stay persistent in doing daily ERP even when you're feeling overwhelmed and lost in pessimism or a specific state of mind? And I think this kind of builds right off what I was just talking about, Chris.
Yeah, you know what? I always love the guests that we have on here, and I learn from so many of them, and it's good reminders. And we had Jenny Yip on like a couple months ago, and what I liked that she kind of reiterated is that ERP should not feel like it's sort of like a stop off of the trail of life. It should feel part of life, and so it's really important. A good reminder for all of us, Lewis, right? Is like the ERP should feel important. It should feel like it's addressing relevant things to you. And I think the way that I stayed, because unfortunately, I was a severe case, I was in ERP for 2 years and then had to go back, right? So for a long time. But I think what really helped me is the ERP was woven into my everyday living. So an example would be I was eating everything with a fork and knife. I had a lot of health related fears. And if my hands were dirty, it wasn't really about germs. It was more, what if I touch some kind of disease and then put it in my mouth, right? So for me, when my therapist and I would go to restaurants or eating eateries around treatment, and eat food and practice eating with my fingers, the reason I think I had motivation is because I could visualize how this would improve my life. I could imagine, hey, when I get back into life and I'm dating or I have friends, I can't wait to sit around a table and share chips and salsa or, eat pizza and stuff. So I think one of the ways that I would add, and I'd love, would love to hear Liz too, but it's just, can you make this feel relevant and feel like it's part of your journey to getting you back to where you are?
Yeah, I couldn't agree more. I mean, I think, first of all, the concept that we have to do ERP for the rest of our life every day is a bit archaic, right? I want to blow that up a little bit. I think that that is one of the disservices that the OCD community does right now is I feel like we continue to provide like outdated education and language in the sense that I feel like we're talking a lot often about like ERP is something you have to do forever. You're always going to have OCD. You're always going to struggle. And that's just not true at all, right? ERP can be a tool that, yes, you need to do it every day actively right now while you're in the throes of your OCD, but that long term, ERP just is the exact same equivalent as living your life. You should not have to every day be sitting down and pushing yourself and forcing yourself and challenging yourself to have to do ERP, to have to do hard things. It should no longer be hard, right? Thoughts should no longer be triggers. They're just thoughts that you have. And so I want us to really think about how we can actively make that shift in our life. Like, how can we, because Chris and I probably, Chris, I can't speak for you, but I know for myself, I lived for decades of my life where I did ERP every day. And I used ERP to function, right? Every day it was like, okay, what am I going to approach? What am I going to address? Like what are my exposures going to be? But it was exhausting, right? It felt like, oh my gosh, if I have to do this forever, this is so hard. I don't really want to keep doing ERP at all. And also, when new stuff popped up that was harder and more triggering, it made me say, why should I even do ERP at all? If like I'm always going to have something worse, I'm always going to have a harder trigger. And so I want to challenge you that if that's where you are right now, or if that's how you understand ERP, and or if you're a clinician and that's how you teach and educate people about what ERP is, that does not need to be what ERP is. That is not what we should accept as effective treatment. Effective treatment in ERP, when done correctly, should give you freedom. It should get you to a place where OCD anxiety dictates none of your life. That doesn't mean you never have a trigger again. It doesn't mean You never get anxious, right? Or you never have an intrusive, sticky thought. We can't control that. But it does mean that it should not feel like you're having to train and like actively do ERP. It should just be the way you live your life, right? And so I always say this when people say, what should ERP look like forever? I'm like, it should look like you living your life freely, right? It shouldn't, if every day it's like, I still have to do ERP. If you're a clinician and patients are showing up and every week it's the new crisis of the week, the new trigger, and you're having to like revamp ERP, how they're going to do it for that, we are doing ERP wrong, right? We are doing ERP to address specific symptoms, not to get to core fears, not to get someone to freedom. And that is an exhausting way to do treatment.
Yeah, I was telling my group this week. So all of the Halloween things are popping up in LA. So you can do like the haunted mazes and stuff. And it's like,
Do you like those?
I love them. I
I
love
knew
them.
you were going to say that. I knew you were going to say that. Oh my gosh, you are crazy.
Oh, you know what's funny though? When I go, I scream like a 6-year-old
Oh
child.
my
I am
gosh, I can't
so,
believe you like that. That
I love
terrifies
them.
me.
Oh my God,
Oh,
it's so funny. I absolutely love them. I love being scared. This one had like a haunted hayride and people come up and like freak you out. I love it. I mean, if you see
oh,
me
do
during,
they
I don't look
touch
like
you?
no. Well, okay, so there's one called the 17th Door in Orange County. People come from around the world to go, and you have to sign a waiver, and they touch you, they throw
No,
cockroaches
no,
on you,
no, no, Chris,
they
no.
shock you. Yeah, it's horrible.
Mm-mm,
I won't do that one. I wonder if
mm-mm,
anybody in this
no.
chat has heard about 17th Door, but the ones that I do, they can't touch you. But no, I was thinking about it. There was like so many things that would have been triggers many years ago. So for instance, like, it's Halloween, there's children running around. I had a lot of harm about like pushing children into things. That comes up. I had to sit on hay and like there's those fog machines getting all over me. I was eating food. I used to hate eating food at like places like that because I'm like, do we know if the city comes out and regulates it? So my point of bringing that up is it's just like you were saying, Liz. It's like technically I probably did 15 exposures at this event, but it didn't feel like I was doing exposures. It was, hey, these are the values that I have. I'm with my friends. I want to do this. I want to have a good time. And I don't care. I do not care if these things are going to pop up because it's more important for me to have a good time. So that was important.
Yeah, and I think what's important to recognize, right, is that like you've done your work to get there, right? You've done the
Yeah.
work on the core fears so that you can be at a place where you can just go and be present and have fun and it doesn't feel like it has to be exposures. I think the flip side is sometimes people who haven't done their work try to use the like modality, if that's what we want to call it, but like they try to use the frame of mind of like, okay, I'm going to live by my values, even though I'm going to be really triggered. But then they're like, okay, I did it. I lived by my values, but I was like triggered the whole time. I felt really anxious. This was terrible. And it's like, well, yes, you still have to do the work, right? You have to have done the core fear work so that now you can go to haunted houses, God bless you, not me, and love them versus going to haunted houses as an exposure, right? You go for fun, but you're
Yeah.
not going for an OCD exposure because they're not exposures anymore because you've done that work. And
Yeah.
so I tell people this because I always, people say, well, how do we? It's like, guys, the ways you can do treatment, you can do ERP that's going to get you to freedom. And when we're holding on, that's what we have to evaluate, right? What are we holding on to? Why are we holding on to it? And how do we start to shift that?
Real quick, I ran into Sheena Shea at the event. She's so if people aren't familiar, she just wrote a book and she mentions the IOCF in it. She has OCD. She was on Vanderpump Rules. She was also our Illumination Award last year, and then she presented it this year. But yeah, we were walking, and all of a sudden I saw her, so we're chit chatting. So OCD represent in the wild, folks.
There you
Um,
go.
the next question I see is at 12:07. Hot Dogs on Top says, do I have OCD because I was born with it or because my dad has it and I was raised by someone who showed me how to live who has it? It's a good question.
Yeah, it's a great question. So we know that OCD is a neurobiological illness. So individuals are born with OCD. It's not something that somebody gave to you. It's not contagious. You didn't pick it up from somebody else. It is something that we are just pre-wired for. Now, you can be pre-wired or what we call predisposed to lots of different illnesses. And for some people, they onset at a specific age. Sometimes they onset at a later age. Sometimes they don't onset at all. So, we don't always know as much about like why do they onset? We know that typically puberty, life changes, big life events are when we see that onset happen. So a lot of hormonal shifts and changes going on. So that makes sense. But it would be more likely that you were predisposed, probably because of genetics. Uh, Environment can play a factor, sure, right? If our parents, for example, if my kid is exhibiting signs and symptoms of anxiety or OCD and I'm doing active, like kind of ERP and like non-reassurance and engagement with their rituals from a young age, it may not ever develop into a diagnosis, and that can be really useful. If I was a parent who is like promoting OCD behaviors, that may be kind of a recipe for it to get worse and for us to not stop it where it needs to be. However, we're born with OCD. It's not something that we inherit from someone else by observation.
Yeah, no, I agree. And I think that, like you said, we're still learning the factors. I think that's one of the things that we're trying to do is there's a lot of research that continues to go into that. So it'll be interesting as it goes along. But I do think like, there's plenty of families where people have OCD and they never experienced family members who kept an environment like that. But then there's clients that I work with, and it's like, yeah, growing up, my parents had OCD and they did this. And, it's interesting how the nature nurture kind of factors come in here. So
100%. Yeah, absolutely. Yeah, so Matt said when he was traveling is a great place to learn to lean into discomfort while having the value that you choose. Disney World is one of his favorite go-tos. I love that.
I've never been to
Um,
Disney World. I should have went when we were at the conference. It was just 3,000 degrees.
yes, so
Uh,
hot in July. Yes.
we have a
Okay,
Oh, go on.
go ahead. No, go ahead.
I was just saying we have a pre-submitted question. Somebody asked, how do we differentiate between psychosis and OCD?
Yeah, great question. So typically, Bob Hudak, Dr. Hudak, who is one of our psychiatrists that we bring on often. I can't remember if you just had him on recently, Chris, or you're about to, but I know I saw it's coming up soon.
I think he's coming up soon. Yeah.
Okay. So Dr. Hudak is really like the leading specialist around differentiating psychosis and OCD. So I think it'd be a great thing for us to have him talk about. But really, one of the differentiating factors is that OCD is unwanted intrusive thoughts followed by repetitive behaviors. And so these unwanted thoughts are thoughts that disturb us, they disrupt us, and oftentimes, sorry for the honking, we know that they are not realistic, right? So we have insight to know that these are not real, and we want to do anything to get rid of these thoughts, right? So we're trying to prove that these thoughts are not true. We're trying to make sure the thoughts aren't valid. We're getting reassurance. We're doing these different behaviors. With psychosis, oftentimes it's the opposite. Individuals are often actually using any information that they gather to prove that these thoughts are true. They're not trying to necessarily disprove these thoughts. And in fact, anything you tell them, they're not holding on to it as something to make them feel better. They're actually using it. They will use it unintentionally, right, as evidence that this irrational thought is actually true. Individuals with psychosis believe, right? So it's kind of more what we would call like egocentric. So with OCD, these thoughts go against our morals and values. We don't want them. We want to get rid of them. We'll do anything to prove they're not true. Where with psychosis, you're often trying to prove they are true. Individuals do believe them to be truth. They don't have insight to recognize oftentimes that these are, they don't always have insight to recognize that these are irrational, unwanted, and not realistic.
Yeah, it wasn't quite the same question, but there was another question that somebody was asking, like, how can I tell if this is just OCD or something else? And I think it's one of the good things to remind people is like when you start treatment, one of the first things that you should do, unless you're kind of seeing a new therapist, when you originally start getting out treatment, make sure that they're doing a thorough assessment. And what that looks like is, are there potential co-occurring disorders? Could there be a differential that needs to be diagnosed because maybe this is an OCD? And so there's been plenty of times where when I've met with a client, they'll start talking about their symptoms, and some of it is absolutely OCD, but then the rest of it might be autism or ADHD or a BFRB, right? So I think it's so important to get that thoroughly assessed, because the last thing you want to do is be in treatment and either a co-occurring diagnosis that you don't get yet interferes with your ERP OCD treatment, or you're getting treatment for OCD, but it's actually something else. So I think it's important beyond just psychosis to really get a thorough assessment to make sure you have what they think that you have. So you're not getting treatment for stuff you don't.
Yeah, and from an OCD stance, what I'll say is oftentimes individuals who are worried about if it's psychosis, it's often OCD, right? Because you're worried about it being that. Individuals with psychosis are not typically worried about if this is psychosis. It's other. They're actually they believe these things to be really true. They don't think they're not true. They're not necessarily concerned about it being psychosis, where individuals with OCD have the fear of having a psychotic illness. Not always the case, but that's just something to think about too. But yeah, I couldn't agree more. I think so many times people don't understand the I don't know what we want to call it, Chris, but like order of operations, so to say, of treatment, right? Which is that the first thing we should be doing is getting an effective diagnosis or diagnoses, right? Sometimes it's one, sometimes there's multiple. You go to treatment first. You don't self-diagnose, right? You don't find, I mean, you might self-diagnose, and that might be why you choose to get that first intake with someone who understands, say, anxiety and OCD. But the what you should be doing, right? The appropriate thing is to go to a provider, you do a full intake. That first session should not be treatment. We should not be doing an intervention. We should be doing a full clinical intake. We're assessing for eating disorders, for sleep, for psychosis, for self-harm, for suicidality, for OCD, for anxiety, for depression, for all mental health conditions, right? We should be assessing for everything and looking at all of your symptoms and figuring out where do they best fit. Right. And sometimes, by the way, at a first intake, we have a clear understanding. Sometimes it takes a couple sessions. It takes more than that to really gather appropriate information, really understand symptomology, talking to family members. Right. So sometimes it isn't just 45 minutes and we know for sure. Right. Some of those things can show up later, can present differently. And so diagnostic pictures might change. And that's important to note. But the reality is that we want that to happen first. Why? Because based on your diagnosis, it will allow us to recommend and or engage in evidence-based treatment for you, right? And so depending on what your diagnosis is, your treatment recommendations should change and shift, right? They should not be the same. If we are giving the same treatment recommendation for any diagnosis, that's actually a problem.
Yeah, can you speak on something real quick before I ask the next pre-submitted question? One of the things that I saw somebody speaking out, they have OCD, and they were like, one of the things that helped them is they realized because of the OCD, their general lifestyle was pretty bad. They weren't really eating a lot of food. Their sleep was really poor, and they were saying like they were frustrated because they finally, when they moved, they finally saw a therapist that continued to do ERP, which they found helpful. But the therapist was like, hey, we got to kind of work on some of these lifestyle factors, like going to bed at 4 or 5 in the morning is not helpful, or not eating because you wake up and you've slept during the day and now you're not hungry, so you're not eating, and then you're more susceptible to morning anxiety. So why, in addition to assessing for co-occurring, is it important to, like, for people watching or clinicians watching, to think like, hey, we might have to look at some other factors as well? Because you had mentioned sleep, so that's what kind of sparked my memory about that post.
Yeah, I mean, I think like the biggest thing I see as somebody who treats individuals with very complex, very severe OCD and comorbidities is when people try to fit people into an OCD box. So as a clinician, I want you to be really thoughtful that like if you're trying to make something OCD, it may not be OCD. And more times than not, individuals with OCD do have comorbid conditions, and it's important for us to figure out what is the OCD if it's there and what is something else that's going on. The biggest pitfall, I was going to say mistake, so I said mistake, pitfall and mistake, new word. But the biggest mistake that I see is individuals assuming, or clinicians kind of making guesses that if someone has obsessions or they have compulsions, they definitely have OCD. Or if this is obsessive or compulsive, it definitely fits OCD. Not always the case, right? Substance use, obsessive and compulsive, not OCD. Even personality disorders and some of the behaviors, right, can be very obsessive and the behaviors can be compulsive, but they wouldn't fit OCD. They are better explained as a personality disorder, or something is better explained as even GAD, right? GAD can look like OCD, but when you really understand it, it is different. It presents different, and the treatment's a little bit different, right? Maybe not drastically, but slightly. And so we want to really make sure that when we do a thorough assessment, we have a really good, sound understanding of what OCD is so that we can assess appropriately and provide recommendations. I see one of the most common misdiagnosis I see is like I see bipolar, often misdiagnosed as OCD. I see personality disorders, often misdiagnosed as OCD. Now, again, more times than not, a lot of these patients I see have comorbid OCD plus bipolar, comorbid OCD plus personality disorder, plus, something else going on, but it's not in lieu of. And so that's really important, is that we shouldn't just assume if you have OCD, all of your symptoms fit OCD, and like we're trying to fit them into OCD, because oftentimes, and you and I talk a lot about this, we will hear people talk about ERP doesn't work for me, but then when we really break it down, it's because it wasn't OCD that we were trying to use ERP, or we were using ERP improperly. I actually have yet to ever hear of someone that has OCD that's being treated with effective ERP not get better. I actually have not come across that. And that's going to feel like a really bold statement. And you guys know, like, I'm happy to make bold statements, but I'm serious when I say that. Now, yes, I've seen ERP not work for people with OCD if the person's not doing ERP, right? So they're engaging with 1 foot in, 1 foot out. They're not fully doing ERP. But I have yet to date ever, in the past couple decades I've been doing this work, see somebody with clear OCD that we're treating that clear OCD with effective ERP, and they're doing the effective ERP all the way, not get better. So that says a lot.
Yeah, no, I agree. One of the things that happens a lot, so we run that family and loved one support group that you're going to be on in November, yay. And we'll get a lot of people that join us the first time, right? And like they'll send us updates and they'll say, thank you so much for this group. It really had me recognize that I need to go ahead and find like ERP for my loved one. Their loved one ends up getting ERP, and we always get emails back, oh my God, it's been a couple months and they're doing so much better. So I think that's why, it's so important to find ERP treatment, is because people are getting better. So I think what Liz is saying is true. And that's one of the things that I always tell people, is if you get the right treatment provider with ERP, that's the same thing I've seen, Liz. Like rarely have I can't think of a time that I saw somebody who like was using ERP, had straight OCD and didn't get better. It's like you said, it's somebody who's not at a place to get better. And sometimes adding in adjunctive or other like treatment strategies works. Sometimes, going back to readiness and really like motivational interviewing. But a lot of the times it really isn't the modality itself. I think sometimes the modality gets blamed, and I hear people say, oh, well, ERP scared them, so they didn't want to do treatment. And when we dig deeper, it's not the ERP. They don't even really know what ERP is yet. They just are like not at a place to even want to get treatment for whatever reason. And so that's why it's like, it's not the modality. It's that person might need help from a clinician to even understand what the OCD is and why it's so important to make the change.
Yeah, I mean, and this happened to me yesterday. I was working with a patient who we were trying to do some more OCD, like we were going to jump into more ERP work. And I realized early on in the session, like, she's not ready for that right now. We need to slow down, and we need to do, I feel like I know what the tapping is. I think it's my earrings hitting my
Maybe
headphones.
that's what it
I just
is. Yeah.
noticed that. So, okay, I need to take those out, or I just won't move, and tell me if it keeps happening, guys. But I realized yesterday in the session, I was like, man, like, we're not ready for ERP today. We need to slow down and have her really be willing to be more bought into ERP can work for me. I want to get better. I'm willing to feel distress, right? Because at the end of the day, if a patient is being pushed to do ERP, but they're not bought into it or ready, it's a guarantee it's not going to work.
Mm-hmm.
Yeah. I mean, it's a guarantee. So well, I'm going to take these out because I can hear them tapping. So I apologize. Okay, so earrings, you shouldn't wear hoop earrings when you have AirPods on when you're doing a webinar. Note to self and others. So Chris, next question. I have real event OCD about a past conversation from the past about a family member's past problem that enters my mind daily. I try to rationalize it from the past, but it keeps coming up. Sorry. Yeah. I try to rationalize that it's from the past, but it keeps coming up.
Yeah, we got a lot of we have a lot of pre-submitted questions about real event OCD and past events. And I think that's what's so tough, is because I think sometimes people hear about OCD and think that it's just something that has no basis in reality. And sure, sometimes it doesn't, like magical thinking OCD. I remember I had a client who was younger, and he felt if he didn't tighten his shoes tight enough, that there could be a natural disaster and really harm his family. So things like that may have no correlation in reality, but there's a lot of past events. This was a talk that I did with Liz McIngvale and Allison Simpson, we had this conversation. We got a lot of these questions like, hey, there's some past stuff that I did in the past, and I can't stop thinking about it. I think about it all the time. I judge myself for it. I feel like I should apologize. I feel like a bad person. And typically this real event has happened 5, 10, 15, 20 years ago, when now, of course, you're in a stage of your life that maybe you recognize the thing you did wasn't like in line with your values, or maybe you don't even really quite remember it. But the mistake that we make, remember, compulsions can take a physical form, but it also can take a mental form. And what we see a lot with this subtype is people trying to relitigate the past. They're trying to go through and replay things. They're trying to get a right feeling or rationalize why it didn't happen or it shouldn't have happened or all of this stuff. But none of us in this room, right, or watching can time machine, right? We can't go back in time and change it. And so if we're clear an event happened in the past and we're feeling guilt and shame for it, that's part of life. We're going to make mistakes, and we have to accept that we're not always going to make decisions that are shining moments, right? But people with OCD seem to get stuck and judge their whole life on one negative moment. Or sometimes clients aren't even really clear about the past, and then they're just beating themselves up for something that may not be clear. So I would say the first intervention with response prevention is saying, hey, just like somebody shouldn't go and wash their hands, if I notice myself sort of leaving the present moment and going back to this event 8 years ago and starting to replay it, that's no longer an obsession. The obsession is what got you to start thinking about the past. Now we're taking a mental compulsion. We're trying to get clarity. We're trying to research. We're trying to fix. We're trying to solve a past event, and that is futile. It can't happen. And all it does is make us feel more angst. So part of the response prevention is saying, look, I may not be clear, or I may have done something I'm not happy with, yet there's nothing I can do about it now. And I have to move forward, even if I feel guilt and shame around that decision.
Yeah, the only thing I'll add on is that I do think sometimes with past event or real event OCD, there is at times a decision that needs to be made. So for example, somebody legitimately had a really bad fight with their family member, and they actually do want to reach out to them and apologize or talk to them about it, but they're so triggered to even think about it that they're avoiding that as well. We need to be careful that it's not going to turn into reassurance seeking and reassurance seeking or checking behaviors. But sometimes part of the exposure might include sending that text message or, re-engaging. I've seen a ton of patients where they have relevant OCD around a certain individual, so they'll quit talking to that individual and they're totally avoiding them. So the exposure will include re-engaging with that person, re-engaging with that place or situation where the triggers might come up and be there, but not falling into OCD rituals around it, right? That clear differentiator of like, okay, here's something I want to do versus now it's become OCD.
Yeah, you know what? I'm going to borrow this from something that Lauren Rosen said once. So shout out to Lauren Rosen. But what I think is so important to help you differentiate is what she said is like, in this kind of situation, is there a timetable and action associated with it? So like you said, the person decides like, hey, upon reflection, that I gave myself a short period of time. I was pretty nasty to my family. My action plan is to apologize tomorrow. That's fine. But if this is now going on a week, a month, a year, a decade, there's no action plan. There's no timetable. It's sort of just this like rehash of the event over and over. And that's how you can tell it's compulsive. There's so many clients I talk to, and I'm like, other people in your situation would take action by now. That's how come, because clients will say, well, other people struggle with this too. Like I have a client who's booking like a Europe trip and they're struggling to make decisions. And it's like, other people struggle with it too, but they have a timetable and they take action. I was like, you pushed off this Europe trip for 3 years because you can't decide what hotel to stay at. That is what's the difference,
Exactly. Yeah. And again, y'all hear me talk about this all the time, but like, what is the function, right? Sometimes it is thoughtful. If I'm picking what school I'm going to send my kid to for kindergarten, like, yes, I want to put a little more thought and time into that than I do when I'm picking what I'm going to order off the menu for lunch. At the same time, if I try to make the perfect choice and I have this analysis paralysis where I make no choice at all and I miss all the application deadlines and everything else because I couldn't make a decision, that's even worse, right? And so it's always like about us saying, is there a decision to be made? If so, like, how do I make that decision? But also, how do I not let OCD interfere or anxiety make decisions for me? And the question I get time and time again, and Chris, I'm sure you do too, is, well, how do I know? How do I know if it's anxiety and OCD versus not? And I always tell people the same thing, which is that actually you do know. when you're like, okay, if I didn't have anxiety or OCD, I actually would go do this thing, or I would call that friend because I'm avoiding them because I'm afraid it might be more triggering, or I wouldn't call and get reassurance again, or I wouldn't send this text because it's checking behavior. Only you actually know. As clinicians, I can help you like decipher, but really like you're the one that speaks your own OCD language, none of us.
Yeah, we got another pre-submitted question from someone close to the show, and they say, "How do you know if apologizing becomes a compulsion? How do you know when or how to actually apologize versus when it's just a compulsion?" One thing I usually ask clients to do is to slow down and ask yourself, like you're saying, the function. So this was one that I also share with this person. Better now, but I used to over apologize. And what helped me is if I was apologizing because I had this like urgent urge and anxiety, and I felt like, hey, apologizing will mitigate the anxiety and extinguish it, that was OCD. If I genuinely was like, holy crap, I did this thing to this person, it wasn't intentional. I really want them to know that I apologize for it and I don't want them to be hurt. That was authentic. So for me, it was like,
Right.
am I apologizing for me? OCD? Am I apologizing genuinely for the other person because I don't want to see them in distress from an action I did either by accident or purposely? That's being human. And I think also the number, like if I have clients sometimes track how much they apologize, and if you're in the 10s, the 20s, the 30s, I'm like, unless you're just a rude person knocking into people at the store, it's probably too much, right? So
Yeah.
it's doing that. Also, sometimes could you use a different word? So a lot of times I was just going straight to like, I'm sorry, just for that. Like somebody was like, hey, were you able to add my client to the group list? And it's like I instead of just saying, oh, you know what, actually I was out, I'll do it right now, it's like, I'm sorry. So I started to notice like, hey, I don't have to apologize for everything that I'm doing. I can instead just kind of explain. Apologies are really reserved for when inadvertently or by accident or on purpose I've hurt someone, and I want them to know that I genuinely feel bad, and don't want to see them in distress.
So I actually, Chris, you actually don't mind if you see people in distress. You're an OCD therapist. Stop
But I
you
mean, like
there.
in real life, like if I'm in
I
real life,
know,
like
but
you know
distress is not dangerous. They'll be okay. You're not responsible for that. Just my like reminder for you. No, I'm just kidding. But I actually just had a session. This is why I was running late. I was running late from a session that went over where I was talking about this because we were talking about like when if your OCD is latched on to like saying thank you or showing gratitude or certain things, right? People are like, yes, but genuinely, like, I want to be a kind person. I don't want to do exposures that I am going to be rude or that I am no longer going to be helpful or nice or appreciative or whatever. And so my answer is always really simple. Are you saying something, sending an extra message, seeking reassurance because you genuinely want to be doing that, or to make yourself feel better? Right? Like that's what I want us to think about. Are we actually responding to a person or an action or, a situation, or are we responding to our own anxiety? Because if we're responding to our anxiety, it's always wrong. It's always not what you should be doing. Right. And remember, anxiety and OCD, it's rigid, it's rule governed. It wants it done in a certain way. It wants it right. And versus like when you're responding to life, there's flexibility. And, I might not say thank you. I might say appreciate you, or like you're the best, or like you're always on top of stuff. Right. Versus OCD, it's like you have to say thank you and you have to hear the person saying it. And I have to hear myself saying it. No one else can be talking. And I have to know that they say you're welcome or that they heard it. Now, all of a sudden, it's losing the actual function and purpose, which is just to express my gratitude. And instead, all I'm actually doing are behaviors to calm my anxiety and how I feel. So when y'all hear me saying what's the function, what I actually mean by that is like, what are the function of our behaviors? Are we doing them because it's actually how we want to live and it's how we want to talk to people and how we want to engage in relationships? Or are we doing them to calm down a feeling inside of us? And that feeling is anxiety.
I think the cool
There's a
thing
bee
is you
by
use
me and
that.
I'm feeling very anxious.
I think you could use that same principle, like for instance, with scrupulosity. Like clients will ask, like, how do I know this prayer is genuine versus like compulsive? And I'm like, is it because you're taking a moment to be thankful for what your God has provided for you and you're checking in and it's something that your faith does? Or is it every single time you have a bad thought, you're wanting to see that anxiety decrease urgently, quickly, and you know you've now associated trigger, pray, calm, temporary, of
Yep.
course. So it could be used for a lot of different
Yeah.
uh
Are you doing that for your faith? Are you doing it to get closer to your faith and because it's a value of yours, or are you doing it for your anxiety?
yeah. I like this
I
question.
feel
As a
better.
parent of a 28-year-old starting ERP, what is the best thing I can do to support him?
Oh my gosh. I love, first of all, just hearing about like someone starting ERP and the parents saying, like, what can I do to support them in this process? Like, so awesome that you're their champion and you're there. I think the first thing I would say is get educated yourself on what ERP kind of looks like and what to expect, because I do think that as a parent, I just did a parent training on anxiety and OCD last week, right? What is natural for us, what our typical responses to anxiety is actually the opposite of what we're doing in ERP, right? So as a parent, when you see people you love in distress and struggling, you want to fix it. You want to make them feel better. You want to rescue them from that pain. That's natural. It's not helpful, actually, and we can have a whole nother episode on just anxiety as a whole and how society has enabled and really like perpetuated this major problem we have in our world and society right now with anxiety. So it's not helpful. However, it's natural, right? It is natural that our natural instinct when people are struggling with anything is to make them feel better. But ERP is quite the opposite of that. So make sure you educate yourself on just what to expect and how you're going to be able to hold space when they're feeling distressed or feeling more dysregulated, which is what ERP will do temporarily, how you can help support them in moving through that versus trying to rescue them from that, right? So we don't want it to be that I'm doing homework, but then mom's giving me reassurance to make me feel better. I'm doing homework, but mom's also cleaning these things so they don't stay triggering. And we want you to be able to support that. Sometimes lots of family members need their own anxiety work because they find that it's really hard for them to hold anxiety and like keep that there and not try to fix that for their loved one or their child. And so again, that's also very normal. That's natural. That's expected. So just be thoughtful of that. But I think the biggest thing is just to support them, to encourage them, to remind them that the progress is not going to happen immediately. Like it is going to take some time. We don't expect ERP that you go to 2 sessions and you're better, right? It takes a little bit of time before you really progress.
Well said. I like this question from Geraldine on Facebook. What can you do with something you can't change? You're stuck for years. And the reason I like this question is because before I really like understood OCD, this was probably the thing that bothered me the most is like I would literally be stuck on things that I couldn't change from the past. And so Geraldine, what I want to pass on to you is if you said you've been stuck for years. When we have OCD, we get stuck. And instead of being able to move forward, that's where the acceptance rolls in. Or if you don't like the word acceptance, you kind of have to just kind of tolerate it, right? What I've always asked myself is, Chris, do you have a time machine to go change that? If the answer is no, the second thing is, can I do anything about it now? And if the answer is no, I have to let it go and let it be. All your power now lies in the present and the future. So let's say we did something that happened or we can't change. I worked with a client where they were really, really angry because they were going to go visit someone who was sick. They just didn't realize that person was going to pass away right away. And they had to reschedule their flight for a week because of something that came up and they've just been stuck on it. Now there's obviously co-occurring grief and some other stuff, but it had been a decade and their OCD just spun on that one decision. And it's like, we can't go back and change that, right? All we can do is learn from it. So if that person is in a similar situation where someone in their life is sick, this time they'll probably make a different decision if they can by kind of dropping some things and going and seeing that person. But we can't go back in time. And I think what OCD is trying to do is trying to fix it and put a pretty bow on it. And we can't always do that. We can learn from situations, grow from it. And like I said, your power is really now is how am I going to move forward with this past event being a fact versus how can I change it or make me feel better about it. We just can't. And I think that's hard for us with OCD to accept. But the second you can do it, you'll get that relief.
Yes. A couple things to add to that. I called my dad on the way over to this talk. So I was talking about the clinic and just like, oh yeah, like how, like what, just, I always like to pick my dad's in the furniture retail industry. So I always like to pick his brain on like marketing and, I'm not good at marketing and he's great at it. And Chris, I'll pick your brain too this week about it. But I was talking about, obviously, like we do residential OCD care, so it's very different with what we do at OCD Texas, and like how to help people understand how to use insurance and all these confusing things that are very difficult. But the one thing I love that my dad said is he just said, sometimes you win and sometimes you learn. And I was like, oh, I really like that. And so I like it in relation to what you were just saying, because it's like, yes, like you're not always going to do perfect with OCD treatment, with anything, right? But it's, can we learn from it? And I tell people that, by the way, even when it comes to rituals, when people are like, I failed, I ritualized, my answer is like, I actually don't care if you ritualized. I care if you learned from it, right? And so, like when we do check in and check out at the clinic, we don't ask, we used to ask our patients, what were your starting anxiety level? What's your ending anxiety level? And how much did your anxiety reduce? We don't ask that anymore. Now we literally say, what'd you work on? Okay, how'd it go? What'd you learn? Right. Okay. Because it's just as important to me if you learn that, hey, I did 10 rituals to try to feel better and I feel worse now than I did when I started, and I wish I wouldn't have done those at all. Great. That's actually just as important as learning as if you do ERP with full response prevention sometimes, And so just remember that like give yourselves grace, but just keep learning and be smart enough to know, hey, what I'm doing isn't working. It's keeping me stuck. It's not moving me forward. I'm not starting to move towards anxiety and towards my fears so that they have no control over me. Instead, I'm continuing to run from them or hide from them, and they continue to control my life.
Yeah, 100%. I think, like I said, this was single-handedly one of the best things that I was able to do. Is I just got to a point where I'm like, fine, Chris, go fix it. And I couldn't fix it, right? I was like, Chris, you're so bothered by this thing that you did and you're upset about it. Go fix it. And obviously, like, I couldn't. I was like, well, I can't go back in time. And like your dad said, it's like, then at least I can learn. I can make
Yes.
different choices moving forward. I would love to go back with the current, that's what they call Monday night quarterbacking. Like, I wish I could go back in time with my current knowledge and go
Oh,
back in time with what I know now and fix it. We all would, right? And this is kind of
yes,
like,
we do things so different.
yeah, it's kind of like a human emotion is like, man, why didn't I choose this? Or how did I get scammed for that? Or man, I never should have gotten that degree because I really wanted to go into this field. I mean, we can literally litigate our entire life, but the problem that happens is we start to feel bad. And that's why I love Kim Quinlan's book on self-compassion. And that's what I hope you can use for yourself, Geraldine, is just say, okay, that past event that I'm really stuck on, I can't go back in time. What, like Liz's dad said, what can I learn from this and move forward?
That's right. And so just remember, the goal with anxiety and OCD treatment is how can we move towards it? How can we approach it? Not how can we not feel it? And so when I see comments of like, I'm crippled with anxiety, I feel a lot of anxiety, my response is going to feel invalidating. So hope know that I'm not trying to invalidate you. I'm trying to invalidate your anxiety and OCD. Right. My response when people say I have a ton of anxiety, I'm always anxious, I'm crippled with it, my response is like, so what? Right? Anxiety is not dangerous. We have to quit treating it like it is. The problem is not if we feel anxiety. The problem is if we fear anxiety. Because when we fear it, it actually owns us. And then we're searching for it, we're scanning for it. And every time we feel it, it's triggering to us. Versus if we actually can like welcome anxiety and kind of have this bring it on attitude, I'm not afraid of you, it can't control you anymore. And that is the goal for anxiety. It's the goal for OCD. That's what we're trying to teach you guys.
Yeah, Matt was saying earlier Shannon Shy, it's like looking at triggers as opportunities. And I know people think that's you'll never get to that point, but I totally get to that point. I love it. I mean, I gamify it in my head. I'm like, ooh, this is a perfect opportunity. I all the time, right? Like when I was at that haunted house that you won't go to and they had food, right? I was like, I want this and it's going to be messy. I know if I eat it, it's going to like my hands are going to be drippy and all that. But that's the food I want. Let's challenge myself. Like I want to leave here and be like, I ate what I want to eat. I didn't eat what OCD wanted me to eat. Right. So that's why I always, feel so.
Exactly. So takeaway messages for today are approach anxiety, approach your fear so that it doesn't get to control you anymore. And the biggest one that I love so much that we've talked about is when we've truly done ERP to address core fears, we get the opportunity to live our life. We don't have to do ERP every day anymore. We don't have to do treatment anymore. We just get to live our life not dictated at all or in any way by anxiety or OCD. So that's what you're fighting for.
Love that. My final thought is just going to be what Ash wrote in the comments. Yes, I remember you, Ash, of course. And Ash told me at their first conference that they wouldn't wish to get OCD again, but I'm grateful because it gave me direction. It's awful, but it was meant to happen for me to get here. And I always think like it's part of our journey, right? And like, you know, Liz's dad said, you either win or you learn. And I think we've all learned having this disorder. That's what unites us. And we have what I always tell clients is like there was a fight deep down inside of ourselves that we have put out, and we have tackled this, and we're getting better, and that will be used for the rest of your life. So it's good seeing you, Ash, by the way. My final thought is just like we've been talking about. I feel like once you get to that point where you've done the hard work and ERP is just part of life, you get to go to haunted mansions and get scared and eat funnel cake and have a good time, and it doesn't feel like an exposure. It just feels like life. And sure, OCD is deep down somewhere throwing a fit, but that makes me so happy whenever OCD is mad. So I always tell people piss off OCD. Thank you all so much for coming out. It's always good hanging with Liz. I love seeing you every time, Liz. Go enjoy that school. That looks nicer than any place I've ever been. And just quick announcements. Remember, we are here every second when we are here every Wednesday of the month at 12 Eastern. Liz is always here on the first Wednesday. The next week is the second Wednesday is what I was going to say. And we always have a psychiatrist on. Also, make sure to go to iocdf.org, especially check out their calendar. I was looking at it yesterday. Y'all, OCD Awareness Week is like 2 weeks away. And I don't know if you saw, Liz, but if you go to the calendar, there are so many events happening for OCD Awareness Week. I know we're doing stuff in SoCal. I'm sure there's stuff in Texas. So the second week of October is OCD Awareness Week. It's something to educate the public, your friends, your family on OCD. So please, please, please check out all that the IOCF has to offer. It's our week. We got to be selfish and talk about OCD all week. So head over to that link and check it out. It's so good to see you, Liz. Final words for everyone to boost them for the day.
Love you guys.
All right. Take care, everyone. We'll see you soon. Have a great rest of your day.